I'm going to kick things off. Hi, everyone, and welcome to MGFA's Wellness Series webinar, Standards of Care for IVIG Therapy During COVID-19 and Beyond. My name is Jenna Umbalo, and I'm the Director of Patient Advocacy and Community Engagement at MGFA, and I'll be moderating today's session. Before we get started, I'd like to go over a few housekeeping items. We're thrilled to have such a great showing for today's event, and we ask that you remain on mute throughout the presentation. Please submit your questions via the Zoom chat located on the Zoom menu bar, and we will answer them during the Q&A segment. Today's session will be recorded and available online. Now, I'd like to give special thanks for the support of our Wellness Series presenting sponsors, Alexion, argenx, Momenta, and UCB, and our supporting sponsor, Immunovant. We've got a great presentation ahead, and now it's my pleasure to introduce today's speakers, James Sheets and Michelle Vogel. James is the founder and CEO of Csi Pharmacy. He's worked over 15 years in IG therapy and has a passion for working with rare disease communities. He decided to specialize in infusion pharmacy out of a personal mission to improve the lives of others. Working together with rare disease patients and disease-specific organizations inspires Csi Pharmacy to provide the highest level of care possible. And Michelle joined Csi Pharmacy in 2016 as VP of Patient Advocacy and Provider Relations. She works with patients to ensure that no patient goes without their life-saving therapy in an affordable site of care. She's a prominent speaker on topics such as Medicaid reimbursement, the economics of the plasma industry, health insurance reform, Social Security disability, navigating health insurance, and patient advocacy. Michelle's hobby is assisting patients to successfully navigate their health insurance policies to ensure that they get covered for the prescribed medications and other services. James and Michelle, I'll hand it over to you.
Okay. Oops. Okay, let's get started with the presentation on standards of care for IVIG therapy during COVID-19 and beyond. James, why don't you just introduce Csi Pharmacy?
Hello, everyone. Thank you for having us with you. It's real exciting to be here in front of wonderful folks at MGFA and your great community. Just real quick on Csi Pharmacy, for those of you who don't know, it's a nationwide specialty pharmacy. We're founded by pharmacists and really focus on patients with chronic rare diseases. We specialize in those diseases, and really around plasma therapies is really what we're known for, which includes things like IVIG.
We work with a lot of patient communities that are in the rare disease area. I have to say we love working with the myasthenia gravis community, partnering with MGFA. And even though myasthenia gravis is such a rare disease, over 30% of our patients actually have myasthenia gravis. Our objectives today will be to describe the do's and don'ts for home infusion, describe the standards of care for home infusion, go over the role of a nurse in home infusion and what the nursing expectations are, and describe standards of care during COVID-19 for nurses, for pharmacists and pharmacies, and we don't want to forget our patients who aren't in home infusion but are going to treatment in infusion centers. James is going to start off going over the do's, and I'm going to take the don'ts. So James, why don't you start off?
All right, thank you, Michelle. So I'm going to go through the do's here. So what we should expect and what you should expect for home infusion nursing. So in home infusion altogether, let's start with the nurses. So nurses should wear personal protective equipment, or PPE, And what PPE is those items and garb that help keep you safe and keep the nurse safe. So we're talking about things like face coverings, face protection, goggles, gowns, gloves, shoe covers. That's all is what's considered PPE. And what we know, and the CDC has made really clear, is that a nurse should be wearing PPE anytime there's a patient interaction. So not just sometimes, and not with just select patients who may have symptoms, but with any patient interaction, the nurse should be wearing PPE. And then another important thing is nurses should also be screened. The patients are being screened for potential infection with COVID-19, and it's important the nurses are too. And so each day they'll get up and the first thing they'll do is submit a screen that goes over whether or not they have any risk factors and what their temperature is, just to help keep you safe as a patient. Another important do is patient screening, and patients, before the infusion nurse even shows up, 24 hours beforehand, I think it's important that the nurse calls, goes through screening, make sure that you as a patient are not at, that do not have any recent risk factors or symptoms that may suggest you have a respiratory illness, and go through that screen. And then the pharmacy staff usually goes over that when they're filling out refill requests too. And then another important do for the pharmacy is the pharmacy needs to pack the medicines and supplies while wearing PPE. And the picture you see here is of a pharmacist or IV technician, and they're in a clean room where they're compounding IV solutions. You know, and in that environment, the pharmacy and technicians have always worn PPE. So, you know, gowns and masks and hair coverings, sterile gloves, those were all things that pharmacists are trained to do when compounding medications. Well, what's unique about the current pandemic is we've taken a lot of those practices that traditionally just took place in the clean room, and we're doing those in other areas of the pharmacy. So frequent cleaning and disinfecting, and then you know, the people who are responsible for packing the medications and preparing them are wearing gloves, gowns, and face masks. And then another finally do, and something that each of you can consider, is you can actually request from your pharmacy to send you some items to help keep you safe, like hand sanitizer or mask. And this is something that we did pretty early on, was send out what we called a welfare package or a care package to patients that had hand sanitizer, mask. It had thermometers, because thermometers were really short. If you guys remember, it was really tough to find them in the beginning. And we wanted to make sure patients had thermometers so that, you know, for one thing, we could screen them before we showed up, and they could take their temperature and let us know what it is, which is a really important practice to do. And then finally, another good practice for the pharmacies is to call and do welfare checks. And for us, we have our advocacy team, which is Michelle's team. They'll call and check with patients, make sure they've got what they need, and if they have any questions about their infusion, you know, they get those answered.
So now I'm going to take on the don'ts. And actually, I have to thank the community for helping us put this list together. Many people inquired if certain things were safe or not. So let's start with nurses starting infusions and leaving patient for any time during their infusion. And that's a don't. We heard some reports that nurses said that it was a new standard for them to start an IV infusion, get it up to the maximum rate, show a patient how to do an IV push of Benadryl in case they had a bad reaction, and how to disconnect. This is not acceptable. Patients can have reactions, and they shouldn't be taking care of those reactions on their own. And it may be too late for them to react, to report it. So nurses need to be with the patient at all times during the infusion. And if you're told that this is what the nurse has to do, then you call up the specialty pharmacy and talk to somebody and say, I want a nurse with me at all times. And then this came up as nurses training patients on self-infusion. I'm not talking about subcutaneous immune globulin. That is safe. Nurse trains a patient, and the patient can then self-infuse. But I'm talking about infusing the intravenous form of immune globulin either through the veins or through a port. We even heard from patients requesting that nurses train them because they were scared that they didn't want to be exposed to the virus. This puts a patient in jeopardy and it goes against standards of care. So we want to make sure if everybody's taking the safe protocols, then the nurse needs to be with that patient the whole time. And then about social distancing. Social distancing does not mean that the nurse can leave the home and sit outside the home or sit in the car and tell the patient to call them if anything goes wrong or the pump starts beeping. The nurse needs to be in the home, needs to be next to the patient, needs to be monitoring the patient in case anything happens. So if you're told that that's a new requirement, not acceptable, report it. In the beginning of COVID, patients were reporting that nurses were arriving without their protective gear, and that they were reporting that they couldn't get masks or gloves or shoe coverings, that there was a shortage. And there were some shortages, but again, of maybe the N95 masks, but that doesn't mean that they can't be in a surgical mask and be safe. And so nurses always need to have the protective gear. A patient is not responsible for getting that gear for the nurse. That is coming from the pharmacy or the nurse agency. So again, there's no excuses for not taking, the protections needed. And that's for both the nurse and the patient. And then finally, when it comes to social distancing, that does not mean that family members are kicked out of the house during an infusion. It's okay for a nurse to say that they would prefer that the family members aren't in the same room during the infusion, especially multiple people, but they can go into another room, but not out of the house. You're putting those people in jeopardy. And so that's just not acceptable. James, why don't you take over the standards of care?
So yeah, here's where we're going to start. So we're going to start with what are standards of care, and just mention the fact that we always have standards, and we have standards in care for nursing, standards of care for pharmacists and other healthcare professionals, and these are established usually by a multitude of different agencies who regulate pharmacy and nursing, but standards of care should always be practiced. And in general, those are in place. And for immunoglobulin therapy, the Immunoglobulin National Society, or IGNS, actually create standard of care. I've had the pleasure for the last few years to be on that committee where we help create the standards for nurses and pharmacists across the country who administer immunoglobulins. But we do have that as a resource. And then nurses and pharmacists can become certified in immunoglobulins by IGNS. So you could be a IG certified nurse, which is an IGCN, or an IG certified pharmacist now, which is something new that we've added recently, and be an IGCP.
So I'm going to start talking about the role of the nurse. So the nurse shall review the patient's 6 rights to medication administration. So that's the right to medication, right dose, right patient, right route. Is it going through a port, vein, or subcutaneous or PICC line, right time, right documentation. The nurse needs to explain the possible adverse drug reactions and monitor the patient throughout the infusion. They need to complete a nursing assessment with each visit, and then they need to stay with that patient during the entire infusion. The expectations for the nurse, they're expected to understand the proper administration of immune globulin, both the IV form and the subcutaneous form, use clinical judgment, be knowledgeable in the disease that they're treating the patient. So for myasthenia gravis patients, the nurse needs to know about your disease. Be an expert in if it's going intravenously, if it's going through a port or a PICC line, know how to access it, de-access it, and maintenance. Monitor the patients for adverse drug reactions. And this is really important, be able to administer anaphylactic medications. Nurses monitor and manage the patient, and they'll be doing blood pressure checks and making sure that there's no reaction going on. We always say that a patient can have a reaction the first time of infusion or the 200th time of their infusion. So never just take it for granted that I'm not having reaction, so I'm fine. It can happen. And so that's why we have to have a nurse there and monitoring you. Also, during COVID, we went to the next step of limiting non-disposable supplies taken into the patient's home, using disposable supplies if available. Again, completing a COVID screening tool prior to infusion visits. So both the nurse is screened and the patient is screened. And I'm sure all of you have gone through the screening if you're going to the doctor's office as well as being infused, where they're asking, they're checking your temperature, asking the questions about any recent fevers, coughs, chills, stomach issues, headaches, all of those, or been exposed to anybody with COVID. Again, wearing that personal protective equipment, the mask, the gloves, the face shield, the booties, and that's all based on the Centers for Disease Control guidelines. And then when the nurse is finished with their patient, they need to reduce the risk of cross-contamination by wiping down their car surfaces, removing shoes prior to entering their personal home, remove and launder their clothing immediately, wipe down their cell phones, pens, and any items used during the patient visit. This is something that is where we put in here just so if someone is going to do home infusion, what does the physician need to do? And really, they need to request home IVIG infusions for the patients for whatever disease it is, submit the request to a specialty pharmacy, and provide the patient's history, demographics, and insurance information. James, why don't you take it from here?
Yes, thanks, Michelle. So let's talk about the pharmacist. So one of the reasons it's important for the physician to send over a lot of that information, which includes your clinical history and what we call an H&P, is because the pharmacist needs to understand that clinical information very well. And it's always a standard that the pharmacist be knowledgeable about the medication they're providing, in particular plasma products like immunoglobulin therapy, because the pharmacist's job really starts when the order is received. It starts with looking at the patient's clinical picture, which may actually influence what brand of IG or immune globulins is chosen. They're all considered to be equally effective in general, but some have different side effects profiles, and depending on what other diseases besides myasthenia gravis you may have, we may choose one product over the other, just to kind of give you the chance to have the best outcomes. Looking for drug interactions. That's why, you'll get a call from the pharmacy just to confirm your medication list hasn't changed. We just want to make sure there's not any drug interactions there. And then we're going to create a care plan really early on, which includes monitoring what labs the physician wants monitored. It puts into place any special requirements for pre-medications or other medications we may give you to lower your risk of side effects. And so the pharmacist is involved really early on in the process with those things and working with the nurse. That's one of the things I love about the field of home infusion is there's a lot of collaboration between the nursing and the pharmacy. And we really become a team together that becomes the eyes and ears for the physician in your home. And then finally, something a lot of people do not realize is that with home infusion, the pharmacy is also responsible for providing the necessary supplies and equipment. So pumps and tubing and alcohol swabs, the gloves, everything you need to administer that medication and administer it safely, right down to the IV sets. And also is responsible for providing the PPE, which we talked about, that protective equipment like face protection and gloves, gowns. That's the pharmacy's responsibility all the time, not just in the current pandemic. So how about during COVID-19? What are some things that's changed? Well, the first is to utilize an emergency planning policy for patients. And we have a gentleman who I think is on the call, I hope. His name is Barry. He's our pharmacist that is over our compliance and operations. And there's really a lot of superheroes like Barry behind the scenes who, the minute this pandemic really started to emerge and become understood, got out there, got ahead of it as much as we could and said, what needs to take place now? And so these emergency plans have always been part of our accreditation, but they've really been geared around something like a hurricane or a fire or some other disaster. And in this case, we realized very quickly that we need to make sure pandemic response is included in this emergency plan. And so we put that into place, which included everything under the sun, from how we were going to screen patients and nurses to making sure we had coverage. What if one nurse gets sick and that nurse is responsible for infusing 10 patients over the course of the month? How are we going to get everybody covered safely? And so really went in and was really thorough at setting a lot of that up. Then again, a big part of that's providing the nurse with that protective equipment based on, the guidance we saw from the Centers of Disease Control and the Immunoglobulin National Society. And there was some shortages in the beginning, especially with, as Michelle mentioned, the N95 mask. But, that was a big part of our emergency plan and response to make sure we got everything we needed for our nurses and patients to provide them with protection, make sure we had multiple sources, in case we came, because we did have some back orders early on, especially, make sure you have multiple sources and even, limiting when it's used, so when is it appropriate for, when we could spare things like N95 masks for more at-risk patients. Back then we did. And then another possibility is to evaluate the patient's lab frequency and extend it. And that's really individualized per patient. If you've got somebody who is, maybe really stable, their disease may be stable, and they're used to getting monthly labs, that some physicians, didn't want there to be that interaction between the nurse and patient as often, especially with subcutaneous IG. And so sometimes labs might go from once a month to once every 3 months. But again, that was physician driven and really depends on the individual patients. And then back to that COVID screening tool, something the pharmacy is able to do is also do a screening when they make that initial call before they send your medicine and talk to you about when you're going to be infused, how are you doing on your medication, how are you responding well with your symptoms, and to incorporate into that this COVID screening.
And then we can't forget about our infusion centers, because many of you are not doing it in the home and are getting infused in the infusion centers. So Infusion centers, we have maintained social distancing with the infusion chairs. Many of the infusion centers reduce capacity by 50%. If they didn't have rooms, individual rooms for the patients, if they had like a 4-chair setup, they would put a patient in 2 of the chairs as far apart as possible, requiring patients to wear a mask during the infusion visit, reducing non-essential personnel during the infusion, and also reducing the number of people that can come with you. So many of you may have experienced that your friends or caregivers couldn't come with you during the infusion, and that's just to cut down on the number of people. Many of the infusion centers extended hours to maximize patient visits. They're screening patients the same way 24 hours prior to a visit, immediately prior to the visit. There may be a setup where you're coming in, and before you can even get into the building, they're checking your temperature and going through the questionnaire with you. They're cleaning and disinfecting all the surfaces prior to and after the patient visit. All the nurses are required to wear all of the protective equipment. Again, the masks, a lot of them are in goggles or face shields, and they've got the gowns and the gloves. And again, the other major change has been patients asked to wait in their cars until their appointment time, not sitting in a waiting room, and then being escorted into the infusion center. So we're here to answer your questions. Ask us anything about, let us be your resource of standards of care. We're here to be of help to all of you.
Thanks so much, Michelle and James. We're going to kick off the Q&A with a couple questions. We've been getting some through the chat. Thanks everyone for submitting. You can keep submitting as we cover some of these questions as well. So the first question we have is from Laura, and her question is, does this information apply to the US only, or is Canada also included?
We're looking at the guidelines that are set up in the United States. However, Canada, I'm sure, has set up guidelines as well. And so you would have to check with who oversees Canada's, like their Centers for Disease Control, and see what their guidelines are. But I think everybody across the world have come up with pretty strict guidelines to make sure that patients and nurses stay safe.
Great, thanks. This next question is from Art. Why doesn't Medicare pay for home IVIG infusions if not homebound? I was receiving home infusions for 2 years at home and had to switch when I became Medicare eligible.
So I love that question because I'm going to tell you right now, you are covered. You do not have to be homebound. And I'm not sure why this is so confusing, but I'm going to explain this to you. This is one of those issues that I am very passionate about. You can get your IVIG. It's not covered under the same part of Medicare as in the infusion center, Medicare Part B. It's actually covered under your drug policy, your Part D plan. And so it's covered well. There is a lot of patients, get a little nervous because of the donut hole before they hit catastrophic, and there's a fee associated. I'm telling you right now, there's so much competition out there among home infusion companies and specialty pharmacies that if you shop around, many of them will provide you with assistance internally to help you through that donut hole so that you're not disadvantaged by going into the home versus the infusion center. You shouldn't have to pay a difference.
That's great. Thanks, Michelle. Shauna asked if you can talk about the standards for vitals and infusions for taking vitals.
Sure.
Absolutely, yeah. So it's IVIG administration can cause changes in blood pressure, can cause changes in heart rate, and all of those things are when we see a change like that is a signal to us that maybe we need to reduce the rate. So really the best standard for taking vitals, which is your heart rate, your blood pressure, is to do it at each rate increase, right? And so most pharmacies, a good practice is to ramp the rate up slowly, even really after you've had IVIG several times. So anytime that rate increases, which is anywhere from every 15 minutes to every 30 minutes, it's important to get a new set of vitals. And then once you get it to a maximum rate, it's still important to monitor those vitals at least on an hourly basis.
Thanks, James. I'm getting a couple questions about a little bit more specifics. So Anne has a good kind of summation of this that says, mine used to regularly take BP and heart rate, but I've gotten less and less monitored, last time only initially. I called her at 3 p.m. and asked for a check-in, and she said she would, but since I didn't have too much of a problem, she didn't feel the need to hover. What advice do we have?
Yeah, no, again, sometimes you won't show the signs till it's too late, that, the patient feels a difference. And so, again, it should be checked regularly. And so sometimes there is an issue where in infusion centers where they may tend not to check it as much as they do in the home. But let me tell you, complain, either in the home or in the infusion center. You're the most important person. You need to advocate for yourself and say, hey, I haven't had my vitals checked in a while. I need you to check them to make sure I'm safe.
Okay, great. Sue had a question. Do you anticipate an IVIG shortage due to the current shortage of blood donations?
Yeah, so this is a little scary, and it's an issue that is of major concern. Once the virus hit, people sheltered down, and especially a lot of places where plasma is collected, where the donors go, near universities and other areas, those universities shut down. So we're seeing plasma donations down up to 40% since COVID hit. And so inevitably, if donations don't go back up dramatically, we're going to see supply issues. And it could hit as soon as the end of this year or beginning of next year. But we're anticipating it. The manufacturers are talking about it. So we've been working really hard to get more people out there to donate their plasma.
Okay, thank you. Judith says, my infusion center nurses wear only masks and gloves for PPE. Is that appropriate since it's in a sterile environment? Do hospitals set their own standards, or is that a national standard?
So the standard set forth and guidance from CDC is national, for sure. It would apply to all sites of care. The infusion center is not what you would call a sterile environment, like you would see in a clean room or a surgery suite, but it is a controlled environment. In that situation, I think gowns are important. It is different than my primary specialty and our specialty, which is in the home, where you've got a gown, you're leaving with gloves, disposing of those. Later, you'll see another patient the next day and be in new garb. I do understand they're in there from patient to patient, but just wearing gloves won't keep you from spreading from patient to patient either. So yeah, it is national guidance, and my recommendation would be they were gowned.
Thank you. This next question is a port usual? I have small veins that are hard to find.
So again, if you become venous access, if you have venous access problems, then many patients go to a port, or the other option is to go to subcutaneous infusions. But if they're able to access those veins, even if they're small, if they're good, then you can continue getting it. It's just when you get to the point where they don't have a vein to go to, then you've got to make some decisions.
Thank you. And along the same lines, we're getting a lot of questions coming in. Simi was asking, what's the difference between a central line and a port?
Yeah, that's a fantastic question. So a port is a central line, but a port is a permanent device that is put in under the skin that has just that, a little port where you could access it and have direct access to that vein. On the other side of that port, the surgeon has run that catheter, the tubing, into the central line. Now, in general, if you hear port, you're talking about that. And if you hear someone say central line, which you don't see in home infusion or for usually for any type of prolonged infusions, it's really short-term patients in the hospital where the surgeon will go in and put in a central line directly into the subclavian vein, so that you're running that medication into a big vein and not causing problems in smaller veins. And so that's a central line. The port also accesses that area. And then another possibility is a PICC line, which is actually inserted like a normal IV, usually in your elbow space, AC space, and the catheter runs up to that same area centrally, but it's peripherally where they access it from your arm.
And that's short term, correct, James? The PICC
So
line?
out of all of those, the longest term is the port, and because they can be kept in place for well over a year. PICC lines are typically 3 to 6 months. Central lines are less than 30 days in general.
Great. Sabrina asked, can COVID be contracted from IVIG infusions?
And that is a great question, and something that when we started to first learn more and more about this coronavirus and about COVID-19 specifically, the manufacturers were quick to address this. And so were we. We shared that information really early. But coronaviruses like COVID-19 are what's called lipid envelope viruses. We're aware of the structure and also the size. And what's good about that is those type of viruses are extremely susceptible to our purification processes during manufacturing. So there's all kinds of way that we keep you safe, or the manufacturers keep us safe when preparing immunoglobulin therapy. One of them is what's called viral inactivation, and there's like 3 different steps where they adjust the pH. They use different chemicals that during the manufacturing process kills lipid envelope viruses and other viruses. So yeah, I think the answer is yes, you're safe from not catching COVID from IVIG, and a lot of it has to do with pre-screening, and then also, like you said, the type of virus that it is.
This is kind of along those lines. Are the antibodies for COVID stripped out when IVIG is processed for use?
Right. So they wouldn't be, right? I mean, so when you're looking at preparing immunoglobulin therapy or IVIG, like we see from what's called polyclonal, or the IVIG that you would get from myasthenia gravis, not some specified form. What happens is the plasma is collected from these collection centers, huge screening process. As I said, there's lots of safety steps involved. But in the end, the manufacturers collect these plasma products. Some of them will be in antibodies, specifically what's called an IgG antibody, which is like the workforce of the immune system. And it captures them all. And your body has literally millions of antibodies designed to focus on select pathogens. And so, yeah, if there is antibodies against COVID-19 in a plasma donor system, you would suspect that those would also be passed on to the IVIG. One more quick thing about that is it does take 6 to 9 months from the time plasma is collected until, or even longer, until it becomes an IVIG product. And so, if you kind of look at the timeline, I don't think it's very likely that there's COVID antibodies against COVID in our current IVIG supply.
Thanks. And that's a good segue into a question Elizabeth has, which is, where does the plasma for IVIG come from?
So it's in the United States. Okay, so for patients, each country, so for patients here in the United States, we collect plasma from US citizens or residents. The plasma donations are, if you're a donor, it's 60-mile radius from where you live. Once they do not use the first donation, they are checking it, and then after that they'll use every donation after that, and then they collect all of it, and it then goes to the manufacturing facility. Some of the companies have manufacturing facilities here in the United States, others have it in Europe, and then it comes, but regardless, if it goes to Europe, that US plasma is coming back here in the finished product. And so you're only using it from US donors.
Okay, great. Jan said, I had IVIG this week at a hospital near my summer home in Colorado. The nurse only checked my vitals before administering the IVIG and never again. I questioned her and she said that their practice is to just visually monitor the patient. I called a triage nurse the next day and she claimed the pharmacy and clinic both said that this is appropriate.
Again, I hear that from people who are more in infusion centers than in the home. The only thing that you can do, and if you feel uncomfortable with it, which I would, is to have the doctor write on the orders to check your vitals, and have him put on in what interval he wants those vitals checked, and then they have to follow what the doctor's orders state.
Yeah, and those vitals, they're, again, for that nurse who's infusing that and monitoring you in the during your infusion, whether it's an infusion center or the home, it's an early indicator if something may be changing or you may be having a reaction to the IG. And so sometimes they can see that, and if they see blood pressure increase, they can back that rate back down to the previous level and prevent there from being other problems, and you just keep going forward. So it's also a monitoring tool that can be used right away by that nurse to adjust that infusion rate and hopefully prevent any further problems with blood pressure or heart rate.
Great. Thank you. This question is from Amy, the Empowered Warrior. How often should neuros be ordering blood labs to check levels for patients getting IVIG?
So typically, patients are getting it each time they're getting their infusion. So if they get their infusion on a monthly basis every 4 weeks, they're getting labs drawn every 4 weeks. Don't you agree, James?
Yeah, and I think it's a good question. I don't think it has to be with every monthly infusion. I think it certainly needs to, if it's a monthly infusion, I think it certainly needs to be in the beginning. But one of the things we're doing with those labs, other than the physician also wanting certain labs to monitor your disease progression, is some of those labs lets us know if you may be having adverse reactions from the IVIG itself. And so We monitor what's called kidney function or renal function, so that if the IG is causing kidney problems, we can see that early before it becomes an issue. We're looking at your red blood cells, because in certain situations, especially with really high doses of IVIG, you can have anemia, and we want to see if any of that's taking place. And so I think it's especially important early on during therapy, when you first start on IVIG. Now, if a physician was comfortable doing it every 3 months, every 6 months, I don't think that would necessarily be inappropriate.
Okay, thank you. We're going to take a couple more questions here before we wrap things up. Judith says that she's got a lot of people asking how to donate plasma. Where should she tell people to go?
So we also, well, MGFA has put out information about donating plasma, but there is a website, and I have to look at that, and we can put information on it, on donating plasma. I think it's donatingplasma.org, and it will tell you, you could put in your zip code, and then you find where your local plasma donation center is. There's a huge difference between donating plasma at a blood center or hospital versus a plasma donation center. If you want it going to make IVIG, it needs to be at a plasma donation center. So we'll make sure that gets, if that's not prominently up on on MGFA's website, we'll make sure it gets up there.
We do have, thanks Michelle, and we do have a link to some resources and information about the plasma donations on one of the banners on our website. So you can check that out there as well.
Okay,
It looks
so
like
somebody
Linda
just posted it. So yeah, it's donatingplasma.org. So I was right. So that's where you go on the website to look for it, and it will give you a lot of information.
Wonderful. Okay, we're going to take one more question. This is from Nick and Lillian. Does the cleaning process also eliminate other viruses, notably Hep B or C, or is plasma rejected from donors who have recovered from Hep B or C and tested for hepatitis antibodies, as the Red Cross whole blood donations are rejected?
Yeah, all of the above, I believe is the answer to that. So, like I said, we just actually started, for the first time ever, I went to go donate plasma because Linda, who just posted that link, and Michelle have really been promoting this plasma drive. And I'd always learned about the safety, but it wasn't until I went myself that I really understood just how stringent their criteria are. So that first time you go, they're doing a lot of testing for specifically viruses like hepatitis and HIV and others, to make sure you're eligible to keep donating. And then those viral inactivation processes during manufacturing, the testing thereafter, especially over the years, has resulted in us having extremely safe immunoglobulin supply.
Yeah, and to piggyback on that, we have such strict guidelines. And so, I mean, years and years and years ago when we didn't, we saw in the blood supply and the plasma supply, HIV and hepatitis. Also, lucky enough, immunoglobulin is low enough on the fractionation that it kills a lot of things, but they're testing it before you can even get to that point. So it's very safe.
Great, thank you. Well, thanks everyone for your questions. We're going to wrap up today's webinar. Thank you for the questions. Thank you to James and Michelle for a very informative session. This will be recorded. This has been recorded. It will be posted on our website. And MGFA will be hosting this wellness series throughout the summer, so please be on the lookout for additional invites. Thanks so much and enjoy the rest of your day.
Thank you, everybody.
Thank you.